Marks the spot. Really good point for plantar fasciitis.
Ah.
Okay, that was what I was going to ask. If this other one's not for plantar fasciitis?
No, it's usually ankle impingement.
Okay.
Somebody has pain in their ankle and they can't quite figure out what it is.
Okay.
So what we're doing here is basically putting traction. Watch my body. I've locked my elbow in, and I'm putting traction and plantar flexion on her ankle, on her foot. See that? I'm creating a vector going this way, and at some point, I will compress her heel into the ankle. When this point disappears, and this is technically a different point, but I do them together because they're almost always associated. So if we're just doing the point in her calf, I go to the place where that doesn't hurt anymore. About there, right? Remember how she jumped when we did it the first time? And then when that disappears, I'll hook my hand around the heel, and I'll compress the calcaneus into my other hand.
Are you
Yeah.
pulling?
I'm pulling away.
Pulling away, okay.
Oh,
Now,
wow.
I'm pulling toward that wall.
So the vector is you're pulling, okay, straight, okay.
Yeah, I'm pulling that way. So I'm pulling away. It's a caudal force. I'm going away from the table, which naturally is going to flex her ankle, right? At the point when I'm happy that the point has disappeared, then I'm going to take it, I'm going to compress her heel into my hand.
Are you still distracting
Yes,
while compressing?
yes. I haven't taken away any forces. I'm only adding forces. Force 1. I'm cradling the dorsum of the foot. See that? Kind of fits naturally in there. The convexity of her foot fits perfectly into the concavity of my hand. Rounds, I grasp it. My thumb's going to kind of hold around the malleolus, right? And I'm just going to fall away. See that? Right,
You lock your elbow with your body.
Yeah. Look, I mean, I'm using my belly. It's all belly. Is there any question or confusion or ambiguity about where the force is going?
Yeah.
No.
Right?
No.
Yeah. Point. Everybody point to where the force is going. That away. Good. And then at the point where I'm happy that the point has disappeared, I'm going to keep this force going by turning my body, right? And I'm going to add, by dropping my hand down, the compression of the heel into the other hand. And it really is going straight into the middle of my hand.
So there is an angle on that. It's not straight down. It's
Yeah. That 45 degrees is safe. And I'm not on the bottom of the heel, I'm on the back of the heel.
okay.
And you're going to feel where it wants to go. It's like a clamshell. It wants to close in. It's articulating here, and we're basically just compressing it. The two hands are going to push together.
The two hands are pushing together, and you're still tractioning.
Yeah.
Okay.
Right? I'm adding forces. I'm not taking anything away. I'm still doing this when I compress with the heel in.
But if you're tractioning, how can you also be putting the two forces together?
Why can I not?
Well, you can put the one force into the one that's where.
Layering, compression.
Okay.
Right?
Yeah.
Now, my left hand is doing traction. My right hand is doing compression of the heel into the foot.
Okay.
If you had two people, would you have one on holding the foot?
No, no. If I had two people, I'd have the other person watch while I did the counterstrain. Point or something like that. That he does as an extension of the extension ankle. What I found is very often these two are coupled together, and I get such good results from adding that in general that it just decompresses the foot. There are lots of wonderful things this does deep into the inner guts of the foot that are really good. So,
Let me look and see.
well, if we're talking about the relationship of opening up the core fascia to the foot, the headlight is right here. And what I'm actually doing is the heel and talus, the heel and foot relationship, controls the flow of the river of chi from the foot up the body. So it's a little useful.
Yes.
This is not counterstrain. This is what?
Not counterstrain.
Very good. Thank you. is you can actually do a lift. Have you seen me do this?
Yes.
Yeah. We do it in the class?
Yeah,
I thought we did it, yeah.
we do it.
So she's lying down and I'm basically lifting the foot off the ankle, and then I'm compressing and balancing the midfoot and the hind foot. And what's happening, if you could watch, you can look at the flower open up of the headlight and feel breath and flow. So this is the non-external force application version of that you're doing when there isn't a lot of external intransigence. If this sort of thing didn't work, or you really were feeling like, oh, she's really off, and I can't get it by the normal way, I'll flip them over and do. Now watch the difference between, now look at the force I'm putting in, right? She'll come do it the way I'm doing it. Look at the force that I'm putting, right, into the midfoot ankle relationship, and then I'm adding the hindfoot midfoot relationship, because she couldn't do this herself when I was supporting her. Feels really good. Feels really good. 3 ankle points. In case they're not secondary points to the client, these points will allow them to walk. But basically, you're going to stabilize the patella and find somewhere at the clock directions, at the cardinal directions. So usually there will be a medial point or a lateral point. Not so common a vertical, a 12 o'clock point, the 6 o'clock point. Oh, that was a little bit jumpy. The 6 o'clock point's there, and all you're going to do is just slide the kneecap down till the 6 o'clock point disappears, which is there. Way more important, just lie on your side just for a second. Good, that's perfect. Way more important are the points in the back. Now, the points, here's the popliteal crease. Do you see it? Okay. The points on the sides of the ACL points. The point in the middle is the PCL point. Okay? I'm going to point and you tell me where I'm pointing.
ACL. PCL.
It's so hard to see.
ACL.
Well, get to where you can see. Come right down there.
So it's right in the crease?
Of the tendon there?
Yeah, of course.
Are they on either side of the tendon?
Yeah, so let me review. Okay. Here's the crease, the middle. Bend your knee. This one. So here's the crease of the popliteal space. The PCL is on either side. The ACL is on either side. The PCL is right in the middle.
Right in the middle.
Okay.
PCL.
Where am I?
ACL. PCL.
There's 2 ACLs and 1 PCL.
Medial meniscus.
What's that?
There's two ACLs and 1 PCL.
How many of you agree?
Yes.
How many of you disagree? Therefore,
I guess I was right.
yeah.
You're either all negligent or you're right.
And it doesn't have to be both points. You know, if you say if one's tender and the other's not, you still treat it, right? But it's possibilities of being either medial or lateral, right? And then the PCL is in the front. And then so now roll back on your back. And then there are 2 other points that are really important. If I were to douse the male space of the tibia, dousing the male space of the tibia, and then we get to the space where the female space comes through, that's the joint, right? And we're dousing the male space of the femur, and we're at the female space. So now I've got my hands on male space, and between my fingers is female space. Okay? What might you call? So remember I talked about last night, in the orthopedic world they say that joint line tenderness is torn meniscus until proven otherwise, right? So this is called the joint line. What is it called?
Joint line.
Good. Joint line, right? And so there's a medial joint line.
Medial joint line.
And a
Lateral joint line.
good. Inside the joint line, inside the female space of the knee joint, are 2 little kidney bean-shaped chunks of cartilage called the
Meniscus.
menisci.
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 There's the medial meniscus
Medial meniscus.
and the lateral meniscus. So the point of tenderness anywhere along the medial joint line is called the medial meniscus tender point.
Tender point, okay.
Okay? The
TP.
point over the lateral joint line, where it exists anywhere in the female space there, is called the...
Lateral meniscus tender point.
Tender point.
Good.
But you get that.
So what is this called?
Medial meniscus tendon.
Lateral meniscus tendon.
Knee.
Patella.
Knee. This, hold on. This is a knee. Patella. Patella. Okay?
ACL. PCL.
Good.
In the joint.
Good.
Medial. Lateral. ACL. PCL. 6 o'clock point.
6 o'clock?
There we go. 12 o'clock.
9 o'clock?
9 o'clock. 3 o'clock.
3 o'clock. Where's noon o'clock?
It is actually time for lunch.
Yay! Oh, let's see
My
that
blanket
recording.
over there.
Okay. PCL is in the middle. Show that again now.
you.
The PCL is in the ACL.
So this is my multi-purpose. Back in the old days, this would be my saddle pad
Yes.
that I would retrieve from my tack room of my van.
Or off your horse.
The ACL, is it on this side of the tendon, right?
But when they're relaxed, it doesn't matter. It's anywhere in there.
Okay.
It's kind of over the tendon, actually. It has nothing to do with the tendon.
Right. It's just.
It's a good spot. That's a good spot. Yeah, yeah. When they're active, I mean that's really sore. It's in the bone. It's where is it?
In the bone.
You are right on top of the tendon now there.
There?
Yeah.
No, tendon's medial of me.
Oh, tendon.
But I wouldn't pay attention to the tendon at all.
So the bone is
But
really.
it's the,
With that? No.
yeah.
Okay, yeah, that's pretty good too. So I'm not going to do patella.
So it's just
I'm going to do ACL because it was the first one I found. The ACL, no, if I'm an orthopedist, now the ACL attaches from the tibia. It's called the anterior cruciate ligament. The what?
Anterior cruciate ligament.
What does cruciate mean?
Cross.
Crossing, right? So the ACL and the PCL cross, right? And what the ACL does is it holds the tibia on the femur. So if we want to test the integrity of it, something called an anterior draw sign or test is I just grasp this and pull forward. And look at how we see her tibial plateau dimple forward. Dimple. There. See that? There. Right?
Let's
Now,
see the
don't
dimple
tie.
now.
Don't tie. So what I get is a very strong endpoint. Goes, you feel it, right? If she had torn her anterior cruciate ligament and I pulled, it would just continue to pull forward. That would be a positive anterior draw.
The doctor
No.
get many of those.
Get some staples out, nurse.
The posterior cruciate ligament attaches from the front part of the femur to the back part of the tibia.
Yeah.
And when we do a posterior draw sign, I push the tibia in, then I'm feeling the draw that way, right? If it were, she has total power. It's also, I'm in a bad heart.